Thank you, John, very much. I am acutely aware that I am the only thing between you and a green beer tonight, because that is a tradition in Boston. So I'm speaking about society-driven development of quality metrics. I have no disclosures to make. So why measure quality? We've gone over a lot of this, but about informed decision-making. Informed decision-making, the surgeon making the right choice, the patient making the right choice, to define quality, like was pointed out before with that Michael Porter slide, value equals quality divided by cost. But the real reason, if we don't do it, someone else will. The patients, the payers, the providers, they all want this information. It'll be used for accountable care organizations, bundled payments, public reporting. If we don't do it, someone else will. And they will do it badly. Current metrics do not take into account what we as surgeons would define as overall quality. This was pointed out by Leanne just now. Things like we are measured on quality on whether or not we use a clipper instead of a razor. It's whether we give antibiotics on time, meaningless abuse, as I like to call it, transfusion protocols, ProPublic. All this information is how we're being measured, but that doesn't reflect the kind of care that we as surgeons think would be most important. So what do we think would be most important? Well, appropriateness, patient satisfaction, patient-centered outcomes, functional outcomes, longer-term outcomes, clinical effectiveness, efficiency, value, all these things are critical and are currently not being collected. So what I'd like to say is that we, the surgeons, need to define quality. And the best way to do that is through surgical societies, because that's where we can come together. There's an economies of scale. There's a fixed expertise in this area. And as societies, we can actually develop the quality metrics for tomorrow. We need to determine how to measure quality. What gets measured, outcomes measures, process measures, good data. Insist on good data, not claims data. We need to determine how to appropriately risk adjust and determine what signifies an outlier. We need to understand what matters most for patients, because we're the ones who take care of patients and we know what matters most to them. And most importantly, we need to be proactive rather than reactive. If we continue to spend our time just on our heels with regards to the latest and worst quality metric that's being forced upon us, then it becomes much more challenging. So I'm going to talk about quality metrics for surgical patients by surgeons. Talk a little bit about the STS, which was referred to before, about the NSQIP, bariatric, and other programs that are out there. The concept here, though, is that a burning platform makes people move their feet. And the history of developing these quality programs really has been a burning platform. What do I mean by that? Well, this was referred to before with regards to STS. When it was reported publicly with regards to surgeon-specific information with regards to cardiac surgical outcomes, it became a burning platform. And STS took that on 26 years ago, 27 years ago now, became their major focus. But it was the burning platform of bad quality administrative data that was publicly reported. That was their call to arms. And now, as was pointed out, this is instituted across the country. 90 to 95% of all adult cardiothoracic operations are collecting this information. There's a trove of NQF metrics that have been created by the STS. And most importantly, they feel comfortable enough with this information that they've created that they are voluntarily reporting this. Voluntarily, they're putting in consumer reports. They say, if we're going to be measured, we want to be measured on the best data. We determine what the best data are. Put this data out there if you're going to do anything. And so they did that. This is consumer reports at hospital level. This is in Massachusetts where we are. UMass Memorial Medical Center, best hospital, reported here. Interesting thing here, UMass Medical Center, when it was first identified this information, when it was publicly mandated in Massachusetts by the Department of Public Health, was the worst hospital, was an outlier. They didn't know it. They were shut down by the Department of Public Health. They rose from the ashes and became the best hospital with these metrics. And they wouldn't have known that. The patients going there wouldn't have known that. They wouldn't have known how to quality improve, but they measured it and they improved it over time. And they did it with high quality data. In Massachusetts, the STS data then is evaluated and reevaluated by cardiac surgeons who look at every death to make sure and how it's attributed and how it's risk adjusted. And so they believed in it enough to shut down that hospital. And then they believed in it enough that when that hospital rose from the ashes, it's now the only best hospital in Massachusetts. So this burning platform, well, we discussed this before. This is how the NSQIP was developed. The VA, about every 10 years, unfortunately, seems to get in big trouble with regards to the media, and someone says they're going to shut it down. And that happened in 1986. And the public mandate was that they need to report their risk-adjusted outcomes. That was developed through the NSQIP. They said, well, we need to do it in the private sector as well, the alpha pilots, the beta pilots. I became in the project in 2001, the Patient Safety and Surgery Project. And now this has become the platform for the NSQIP in how the American College of Surgeons and their inspiring quality platform across the country. This is now 10, 12 years into what's the NSQIP, and it's developed remarkably over that time. Well, in bariatric surgery was also pointed out the burning platform that we had. Exponential increase in the number of surgeries performed, horrible outcomes that were being publicly reported, gastric bypass surgery gone bad. 1 in 50 people die within a month of surgery. And that's quoted from that Dave Flum article that John pointed out earlier. The CMS proposal for non-coverage, they said they weren't going to cover bariatric surgery, and that was reversed for a coverage after the non-coverage proposal with the coverage determination requiring accreditation. So the American College of Surgeons program is now joined up with the ASMBS data collection program into the MBS AQIP. It's a mouthful, Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. And that includes 100% of data of cases that are collected at those hospitals, not a sample of cases. Bariatric-specific data points, audited trained data collectors. It looks at clinical effectiveness. It's not just death and destruction. It looks at weight-related comorbidities, diabetes, hypertension, high cholesterol, gastroesophageal reflux disease, sleep apnea. It's not just 30-day outcomes. It's 6 months, 1 year, and annually thereafter. And it's high-quality data. Here's a data report. It's supposed to be small. Don't look at it too closely. This is our data. But it does show that we can compare over this data collection program here. We can compare 1,200 cases at our institution to 200,000 cases across the country. So real numbers, risk-adjusted, and procedure-specific with standardized processes of care and standardized information. A lot of information. And then again, this is death and destruction here, but you can also look at effectiveness, whether or not the BMI reduction is better at your hospitals or at other hospitals, or whether or not their diabetes or sleep apnea or hypertension goes away over time. And it's procedure specific in your sleeves and your bypasses and your revisions. So currently about 800 programs collecting 13,000 cases each month and averaging more than 1 site visit a day since September of 2014. So this is happening right now. And we applied for and were accepted as a CMS, PQRS, QCDR, and VBM. Of course, you all know what that means. But basically, Doug earlier talked about the hospital value-based purchasing. Well, specifically at the Part B, at the physician side, there's physician quality reporting. PQR is Physician Quality Reporting System. And part of the ways that you can report for that is the Qualified Clinical Data Registry, the QCDRs. So basically, CMS is saying, okay, if you want to be measured for quality and you say you have good quality data, then apply and use your good quality data for those metrics. And so we took them up on that. And that's what a QCDR is. The MBS AQIP and the STS are both QCDRs, and we're able to, at the physician level, create reports with regards to those patients. And we heard a little bit earlier about the dollars that are at risk going forward. This is, again, at the physician-specific side. And it's not just on your bariatric operations, it's on all your Medicare reimbursements at the physician-specific side. But just as importantly, on physiciancompare.gov, you're going to be able to look at Matt Hutter up there, and it's not just going to say whether I use clippers or razors, and it's not going to say whether I use meaningless abuse and documented some medications, but it's going to say what my QCDR metrics are. There are 9 of them, and we have risk-adjusted complication rates, risk-adjusted readmissions, reoperations, leaks, bleeds, surgical site infections, nausea, vomiting, extended length of stay, and care coordination with follow-up rates. Those are our current metrics. But again, we can do better than that. With regards to the data collection program, we try to continuously improve upon this with new treatments and new therapies that come out. The sleeve now is the most popular operation. Before there was a CPT code, we started capturing that. Balloons are right out there now, and they were FDA approved in August. Well, as of January 1, we now capture endogastric balloons. Emergency room visits, we've started collecting information with regards to that. Going forward, we're going to capture all interventional therapeutic procedures, whether it's gastric artery embolization or if it's stitching or endostapling or barriers or things like that. The V block will be started in July. We'll be including the novel techniques and technologies, so a way to monitor the safe introduction of novel techniques and technologies. We're going international, and international programs can be data collection programs, and people who aren't even involved can start collecting this data too, just to see what the data collection program is like. We're also developing patient-reported outcomes. So here, now we know what PROMs mean. Thank you, Leanne, for that definition before. But we're developing through PCORI, the Patient-Centered Outcome Research Institute, with a grant that was funded for 4 years for $3 million. We'll be able to develop patient-reported outcomes and institute them into the national data collection programs. The American College of Surgeons, so we highlighted how they developed the ACS NSQIP and the MBSA QIP. There's also the cancer database, the trauma database. There's a breast database, surgeon-specific registry, and what the future registries look like, it's not entirely clear, but there's definitely room to grow in this area. One of the efforts that we've been trying to do is to work across societies in order to do this. So this effort was to develop quality metrics for all of complex GI surgery. It's hard to do this, and it takes a lot of time and effort. So working across SAGES, SSAT, ASMBS, ASCRS, HPBA, IPEG, in order to try to come up with what complex GI surgery metrics would look like. Well, that process is probably too complex, because when you try to get all these societies together, it doesn't work very well, and we're learning that. So really, at the society level might be the best way to do that. And societies are doing this. The American Hernia Society and the American Association of Endocrine Surgeons have been working with Arbormetrics. You heard Dr. Dimmick's disclosure before. He's a co-founder of Arbormetrics. But with this for-profit company, they're able to leverage technology in order to decrease the activation energy to make it easier for these small societies to come up and collect this kind of high-quality data. And America's Hernia Society is doing that, and the endocrine surgeons are doing that as well. And so that's a definite great opportunity as well. Here's some data from the American Hernia Society. This is from Ben Poulos, and specifically looking at the increased number of ventral hernias that they've been capturing over time, and this is gaining traction in their society with increased number of sites across the country. And this is all provided free if you're a member of the Hernia Society. The rectal surgeons are developing this as well, the ostrich, optimizing the surgical treatment of rectal cancer. And so there are a lot of different groups with different surgical societies who are identifying this as a critically important time to do that. So the burning platform makes people move their feet. I talked about cardiac surgery. I talked about the VA developing the NSQIP. I talked about the CMS non-coverage proposal that left to bariatric surgery. But when you look across all of surgery right now, we all have a burning platform. The Affordable Care Act, this value equals quality divided by cost, accountable care organizations, bundled payments. We have to measure quality well. It's physiciancompare.gov. They're putting this information at physician-specific level right out there. And the newspapers are starting to get in the game as well, and they're using administrative data and administrative claims data to show how much you're being paid from these different groups as well. The anesthesiologists are developing a perioperative surgical home. So they're saying, hey, you surgeons, we can define quality and define the episode of care around your surgical patients. You do your thing in the operating room, the rest of us is ours. Any anesthesiologists here? Excellent. Good effort. But it has actually spurred our leadership in the American College of Surgeons to say, wait a second, we need to be at this game. So when there's this burning platform from all these different areas, it really does up our game. ProPublica, they're the ones who are deciding who the bad surgeons are or who the good surgeons are. And U.S. News and World Report are using blunt instruments like low-volume hospitals in order to identify this. She was butchered, he says. There's no other word for it. Yet when I asked whether the patient was told that she was at higher risk because the hospital's low volume, the answer was no. So we, the surgeons, really need to define quality. We need to determine what to measure and how to measure it. We need to determine the data points, the data definitions. We need to insist on good data and not just claims data. We need to determine how to appropriately risk adjust, what signifies an outlier, and really what matters most for our patients. And we need to do this now because the platform is not here, but all of the platform is actually burning. So I'll sum it up with this. If you're not at the table, you're on the menu. So I encourage all the surgical societies and surgeons out there to be at the table because otherwise we will be on the menu. Thank you very much.